So again, apologies for our camera problems, and I'll pass off to the great attendings and faculty and speakers from the University of Virginia Department of Orthopedic Surgery on the topic of cervical deformity. Dr. Lockey.
Morning, Dr. Chapman. Morning to your audience, and great to meet your visitor from Kenya. I can relate in my own having traveled there to visit with you. Sorry, give us 1 second. And my memories from spending time with you and at the Seattle Science Foundation at Swedish are some of the best of my early time as an attending, and I want to thank you so much for having us. We're, like you said, at the University of Virginia here in Charlottesville, Virginia. A little bit later in the morning for us, so thank you for joining us on the West Coast. I am just so lucky to have outstanding partners and mentors. This is our division here at the Department of Orthopedic Surgery at UVA. We're joined today by our division chief, Francis Shen, and then my senior partner and professor of orthopedic surgery, Adam Scheimer. Josh Lee, unfortunately, is operating this morning, was unable to be here. So to start us off, we have our fellow, Zishan Akhtar, who's done a great job for us this year. He's going to start off with our first paper, and then we'll go into some discussion.
Hey, good morning, everyone. My name is Zishan Akhtar. I'm currently the fellow here at UVA, and I'll be talking about this article, Natural Head Posture in the Setting of Sagittal Spine Deformity, Validation of Chin-Brow Vertical Angle, Slope of Line of Sight, and McGregor Slope with Health-Related Quality of Life Outcomes. Basically, this was an imaging study that was done out of HSS to assess the role of head position and horizontal gaze and the relationship of disability and deformity elsewhere in the spinal axis. A little bit of background information. Visual input is obviously, as we all know, critical in our role in maintaining stability as well as adapting to sensory inputs. Having an erect posture as well as a neutral head position are required to maintain the stability. They allow for minimal energy expenditure as well as allow us to maintain that horizontal gaze in order to take in that sensory input. The geometric assessment of this was first described by Simmons in the AS, the ankylosing spondylitis population, to help quantify the flexion deformity in the thoracic segments. Since then, it's been extrapolated, used by spine surgeons now in both the preoperative and postoperative setting to assess cervical deformities. The CBVA is defined as an angle between a vertical line as well as a line that goes from the brow to the chin. And the purpose of this study was basically to define a relationship between CBVA and two more available measurements, as some of the weaknesses or limitations of the CBVA is that oftentimes maybe the chin and the brow are not included in the lateral cervical x-ray. And so they wanted to look at its relationship with the slope of line of sight as well as the slope of McGregor's line, which are two more readily available measurements, and then correlate those to health-related outcomes. Next slide. So methods for the study: this was a single center retrospective analysis that was done of patients seen in a clinical spine setting in November of 2012 to 2013. Adult patients who underwent full-length EOS imaging. Neuromuscular patients, tumor and spinal fractures were excluded. Since they had full-length EOS images, they were able to get a number of radiographic measurements, including cranial cervical measurements, global spinal measurements, as well as regional spinal deformity measurements, and then correlate those with clinical review of their demographic information, their health-related quality of life outcomes, and ODIs. The two key radiographic measures outside of the CBVA that they were interested in were the slope of McGregor's line, which is a line that goes from the posterior aspect of the hard palate to the most caudal aspect of the occiput, and then the slope of the line of sight, which is a line or horizontal line in the angle of Frankfurt's line, which is from the inferior margin of the orbit to the top of the external auditory meatus. Statistical analysis was run with Pearson correlations in order to establish correlations in the linear regression analysis, and then quadratic regression analysis to help define their predictive model. Next slide. So the results of this, they were able to first define a correlation between CBVA and SLS and McGregor slope. This correlation basically defined that all these measurements were able to give an accurate depiction of a patient's horizontal gaze and their cranial sight and space. The ODI was then also found to be significantly correlated with CBVA and be a marker of disability. After making these correlations, they were then able to create a predictive model model where they set 40 as the ODI threshold for severe disability. And in running their model, they were able to find that a CBVA of negative 4.8 to 17.7 were the patients that were more likely to be in the low to moderate disability categories. They then stratified the gaze of patients in ascending, neutral, and downward gaze. Ascending gaze was defined as a CBVA of less than 4.8, and they found that in this patient population, it had significantly more thoracolumbar malalignment. So you see in the chart there, positive p-values for pelvic tilt, PILL mismatch, and then the T1 angle. And then on the right, there's a chart that just shows their predictive model. The ascending gaze patients were also outside of the thoracolumbar malalignment, also noted to have significant differences in almost all the cranial cervical alignment measurements, most significantly their smaller cervical plumb lines. And then they had greater amounts of upper as well as lower cervical lordosis as well. So we can go to the next slide. These findings all just, the cervical findings, I think, just further demonstrate the compensatory mechanisms that these patients have to perform in order to keep their gaze as horizontal as they can. So neutral head positioning is obviously critically important for minimal energy expenditure and maintaining that horizontal gaze. This study was able to demonstrate that the SLS and the McGregor's line were positive correlations and could be correlated to the CBVA, and that all these measurements did correlate to health-related quality of life outcomes and were predictive of disability in their predictive model. They did not, however, notice any global alignment parameters that were different between the neutral and the ascending gaze. So the SVA, the T1 SPA, and the T9 spinal pelvic angles all were not significantly different between these two groups, but they did have those regional deformities that we discussed with the PILL mismatch, the pelvic tilt, and the retroversion of their pelvis. Again, compensatory mechanism to maintain their gaze. Next slide. So the slope strongly correlated, and these values basically are here to provide us with general guidelines and to help us define which patients would be more at risk for having higher levels of disability from having these variations in their horizontal gaze as defined by the CBVA. And then they can help us also further define the compensatory mechanisms that these patients are utilizing in order to keep their horizontal gaze.
Great. Thank you, Zishan. Dr. Chapman, any comments? Sorry, Dr. Chapman, we're having audio issues. We can't hear you.
Okay, can you hear me? Sorry, I have an echo. So appreciate this very much. It's a great way to start because we really don't know how to measure the cranium relative to the rest of the spine. And this is a very constructive way to look at it. Here are my questions. So I'm speaking slowly because of an echo here. So we found, and we have not published that yet, that our patients, when we get whole body x-rays, really have different angles depending upon what the x-ray tech tells them to do. I don't know whether you've seen that also, but we've seen distinct differences from one patient with one x-ray tech to the next x-ray tech. So the instructions and the methods of a patient of how to stand straight are actually quite important. I don't know how the authors assess that. And then question 2, the McGregor line requires that we see the posterior edge of the hard palate to the lower cortex of the opistheum. And how reliably can we actually measure this on an EOS compared to like McRae's line, which measures the pure foramen magnum angle? So why the McGregor line on EOS versus McRae? Thank you.
Sharm, do you want to? We have the EOS. Have you found in your practice here that there's been variations depending on tech and and maybe if you've seen patients multiple times and follow up, are you seeing angles change depending on how they're instructed to position within the X-ray machine?
Probably seen me. I don't know if I've seen it. I think the concept of cervical deformity, how that is part of the global spinal alignment is a newer concept. I think that we have a pretty keen understanding of kind of global spinal alignment for the lumbar and pelvic anatomy. I think we're just kind of wrapping our head around what is normal cervical alignment. I think that's still an argument. So I find value in both a long-standing EOS film, not the brand, but that's the technology, and actually cervical films, because I feel like the EOS sometimes loses the definition of the cervical anatomy. So I'm probably not answering your question. I'm sure the answer is yes. I don't think we have a standard way for each patient to stand. I still get plain cervical radiographs with my dynamic imaging on cervical dynamic lateral imaging on
Cervical spine. Yeah. Dr. Shen?
I think the fallback in most institutions in today's day and age, cervical radiographs, because the availability of long-standing films is not going to be widely available, but it will become. And as we get more data, our understanding is going to vastly change. I suspect, as Dr. Chapman said, that there is a big difference between the way patients consider. We've seen it when we talk about cervical lumbar deformity. We know that just having their hands either in front of them or up at their chest, and the color clavicles changes all the parameters in relationship to the X and Y axis. It may not change the internal diameters, but also hip flexion, knee flexion also changes. So if we extrapolate what we already know for lumbar deformity, I think we're going to find even more subtle things. The occipital cervical junction adds on another problem when we start looking at horizontal gaze. But the more important thing is, to Dr. Shire's point, is and Dr. Chapman's point, everybody's, what do we do with this piece of data? Because do we know that pure horizontal is really where we want them to be, or do we want them a little bit down to be able to see their feet, but they can't sense their feet and they can't see their feet? Is that a problem? And how do you get somebody to do daily living things like swallowing and talking if your head is extended and you're trying to be able to swallow? So this is important data that we start with, but then we have to sort of try to figure out extrapolate clinically, and that's going to be very patient focused too.
Absolutely. And I think we're going to talk about this in one of our later papers, but one of the challenges is, do you restore someone's horizontal gaze in the setting of a thoracolumbar deformity that's ultimately going to need to be addressed? Because if you do the first and then you ultimately do a large correction of the thoracolumbar spine, how does that affect your initial correction? And do you ultimately put them in a negative chin brow angle, and their patients are not particularly happy about that? So I think to highlight the points here and to answer a little bit of the overall question, Dr. Chapman, I think multiple data points are really critical, and seeing patients back, getting those flexion extension views, getting our full length standing views, and seeing them multiple times and seeing how those parameters evolve is probably the best answer that we have at this particular stage.
But great article. Thank you, Dr. Aftar.
As Dr. Lockey mentioned, we'll talk about it at the future paper. I think we did a really nice job of kind of having each paper build on the next one. I think even to get the general spine cervical population thinking about cervical deformity is a good first step. I mean, if you think back to lumbar spine surgery, simple degen 1, 2 level, 3 level fusions 20 years ago, there was no real concept of alignment. People were fused flat, which led to multiple subsequent issues. So I think the very nuanced, granular, high precision data is good for thought leaders like in Seattle, but I think for the general population, even thinking about cervical deformity and not creating cervical deformity is important as well.
Great points. Okay, next we're going to have Dr. Wong give a talk on this paper, cervical scoliosis in a clipal file patient. Dr. Wong is currently one of our fourth-year residents and applying for spine fellowship. Jesse.
All right. I want to thank the Seattle Science Foundation for the invitation for the Virtual Spine Journal Club. Today I'll be talking about the cervical scoliosis in a clipal file patient. As mentioned before, I'm one of the residents, PGY4 at UVA. So a little bit of background. So Klippel-Feil syndrome is the congenital fusion of greater than 2 vertebrae. There's still not a great genetic explanation for why this happens, but the classic triad of Klippel-Feil is low posterior hairline, short neck, as well as a decreased cervical range of motion. Just other associations, congenital anomalies associated with Klippel-Feil syndrome. Typically, there's sometimes to have Sprengel's deformity, hearing impairment, synkinesia, congenital heart and renal disease. In one cross-sectional study by Thompson et al. Noted in one cohort of patients, 70% of scoliosis was noted in that patient population. However, it should be noted that these were mostly thoracic scoliosis. To date, there hasn't been a great study looking at cervical scoliosis as well as how it relates to cervical-related symptoms. So the aim of the study is to assess coronal cervical alignment in a series of patients with Klippel-Feil syndrome and manifestation of cervical-related symptoms. So this is a retrospective case series of 35 patients with Klippel-Feil syndrome in a single institution, the Shriners Hospital in Chicago, between 1984 and 2004. The inclusion criteria is patients with no history of cervical spine surgery, as well as those with complete clinical imaging records. 30 patients total met the inclusion criteria. They also collected the radiographs of cervical and high thoracic region, including the AP, lateral, and flexion extension views, mainly looking at the location of the fused segment, the sagittal and coronal alignment, as well as presence of other vertebral malformations, particularly vertebral bars, full or semi-segmented hemivertebrae. Demographic data and clinical spine-related symptoms such as neck pain, radiculopathy, and myelopathy were obtained. From the results, the mean age of this study cohort was 13.5, so this was mainly looking at pediatric population. The most commonly fused segments were C23 and C56 and C67. Scoliosis in this particular cohort was noted in 53% with a mean Cobb angle of 18.7. 40% of this cohort had malformation in addition to the fused vertebrae. So they had either unilateral non-segmented bar or fully or semi or non-segmented hemivertebrae. When they divided these two groups to look at them individually, they noted that in the group with malformation, they had higher rate of scoliosis at 62% compared to those without malformation only at 37%. Based on a prior study from Samartzis et al., there was a classification of Klippel-Feil syndrome specifically looking at the cervical spine. So type 1, 2, and 3. Type 1 is only a single congenital fused cervical segment, such as the top right figure showing a 14-year-old with a single fused C23. Type 2 is a multiple non-contiguous congenitally fused segment. So in the middle figure, it's a fusion in a 6-year-old with occiput to C1, C23, C45, and C6T1 fusion. Type 3 is multiple contiguous fused segment. In this case, there's an 18-year-old patient with C2 to C6 congenital fusion with a hemivertebrae. So when they divided this cohort into the 3 different classifications, there were 5 patients with type 1, 15 patients with type 2, and 10 patients with type 3. It should be noted that no patient in the type 1 group had scoliosis. In the type 2 group, there was an average of 17 degrees of Cobb angle. And in type 3, there was average of about 29.8 degrees of Cobb angle. Next, they want to look at the location of the fused segment and how that relates to the Cobb angle. They categorize into high, mid, and low. So high is occiput to C2, middle is C2 to C4, and low is C4 to T1. As you can see from the top bar graph, most of the patients with scoliosis had a fused segment in the lower part of the spine, C4 and below. Next, they performed a multivariate analysis, linear regression, to look at location of the fused segment. So patients without scoliosis, the average number of fused segments was 2.8 compared to patients with scoliosis, and average fusion was 4.1 segments. As you can see, there's no difference in the sagittal alignment between the two groups. Next, they wanted to correlate with symptoms in regards to cervical scoliosis. So in their cohort, 33% of patients, or 10 out of 30, with Klippel-Feil syndrome had cervical-related symptoms. About 40% of these were myelopathy. So in this chart, it shows patients without scoliosis. There was only 2 patients with vertebral malformations compared to 10 patients, or 83%, in a scoliosis group with vertebral malformation. However, there were no difference in statistically difference in terms of rate of cervical spine related symptoms between a scoliosis and a non-scoliotic group. The major findings from this article: there was 53% in this young Klippel-Feil syndrome cohort with cervical scoliosis. The major risk factors is multiple contiguous fused segment, or type 3 group, those with vertebral malformation, as well as those in the mid to lower cervical spine fused segment had the highest rate of scoliosis. However, in this study, presence of scoliosis may not be significantly associated with cervical spine related symptoms. This is one of the first studies to characterize radiographic risk factors associated with cervical scoliosis and Klippel-Feil syndrome. Even when controlling for cervical malformations, type 3 patients continue to exhibit high coronal Cobb angles. The proposed thought is due to longer fused lever arm, there's more stress on each vertebral body, resulting in coronal deformity. Limitation of the study: there's a retrospective analysis at a single institution, particularly a pediatric institution. So symptoms do not necessarily correlate with the older Klippel-Feil syndrome population. And then there were no patient-reported outcomes for symptom measurement for an objective measure. Future directions is to investigate the role of age, hospitalization, sagittal alignment on coronal alignments, and subsequent development of symptoms in these patient cohort.
Good job, Jesse. I wanted to ask a quick question, if that's okay, Dr. Scheiman, to our panelists that we have here. So obviously this is at the Shriners, and a lot of these children have syndrome-associated conditions, but a lot of times we see Klippel-Feil incidentally, right? We bring patients in and we get an X-ray, and there's failure of segmentation. And so Dr. Scheimer, in addition to his practice here, is also our spine chief for sports in our robust athletic environment here in Central Virginia. And Dr. Scheimer, if you could comment on, do you have obviously the type 1s that don't involve the occipital-cervical junction, they're asymptomatic. Obviously, those can be cleared for contact sports. And then anyone who's a type 3, multiple segments, or if they're symptomatic, it's the type 2s in this, or if there's more than two fused segments. How do you go about counseling patients and families when it comes to athletics and contact sports and some of those that are in between?
And I think you hit on key components: contact sports, and defining what contact sports is.
Right.
Clearly, American football is the classic, but I would argue rugby, ice hockey, or other contact sports, wrestling, when you get thrown on your head. Type 1s I treat like a single level ACDF. We know that they're pretty good. Well-heeled ACDF are pretty evident that those can return to I think I would take it on an as-case basis and also combine degree of stenosis with it, and also sagittal alignment, right? So I think if they're straight and stenotic, I would treat it like multiple segments and probably not allow them to return. They have relatively well-maintained sagittal alignment, no high-grade stenosis. Then I think I'm a little bit more permissive. I found that early on, I was probably a little bit more restrictive than I am now. It's funny, when you become more experienced, you're actually a little bit more permissive of letting people play, because I think early on you're just so panicked about everything. So I found actually my appetite for
no, that was very helpful. I think that the twos are the ones where it really takes the art and the experience of this and counseling patients and families. Dr. Chapman, any comments? Sorry to take up the initial time there. Sorry, Dr. Chapman, I think you're muted.
Corey is doing this to me, so she doesn't want to hear me. I'm cameraman and audio engineer. First of all, I want to congratulate Dr. Shen and Dr. Lubitsky for this landmark paper and for all of our residents and fellows as a key reference article. This is important. My question is, Clip-O-File is super interesting for us in several angles. One is, what is the rate of adjacent segment disease relative to fusions? And as we look at the iatrogenic effects of fusions and adjacent segment disease, nothing is a better corollary than looking at Clip-O-Files and their natural course history. So if I ask my illustrious UVA colleagues, what is the correlation of adjacent segment disease as we enter adulthood relative to numbers fused and malalignment in both sagittal and coronal plane?
Dr. Shen, would you like to comment on that?
Yeah, I think like all really well-constructed questions that you had with Jens, this is nuanced because you said the number of segments and then you very subtly put in as well as alignment. I think as alignment gets farther off in both the coronal, but particularly the sagittal plane, its effect gets compounded. So if you have a malaligned spine in a single segment, it might be more problematic than a two-level fusion that has a better alignment. And so it's so nuanced that I think it starts to become understanding the whole picture and what they're responsible. So I haven't really answered your question. But the other thing I think is subtle with Clip-O-File is that, number one, you said it too, coming out of the Shriners, Dr. Lockey said it, it's very syndromic. So this is not the asymptomatic 2-3 segment that we see on a plain radiograph incidentally. These often were kids who were 8, 13, and if you're at the Shriners, there's a reason you're at the Shriners. You're not just showing up for neck pain. So I think a single 2-3 Clip-O-File segment noted incidentally, type 1, probably asymptomatic, treat like a long dent, and you could probably be okay. A type 2 that has a 4-5 with 2 open segments with a 2-3 is very different than a 4-5 and a 6-7 an open segment. So I do think that second segment, whether it's a 2-3 asymptomatic, probably changed it. I think the natural history of an asymptomatic Clip-O-File at 2-3 is probably unchanged from a normal asymptomatic patient without a Clip-O-File. I don't know that for sure. I do think a Clip-O-File at 4-5 is a little different though, or 5-6 with that alignment.
On to our next paper. Dr. Shen, our division chief and the Warren G. Stamp Endowed Professor of Orthopedic Surgery, is going to present our next paper discussing the predicting of combined occurrence of poor clinical and radiographic outcomes following cervical deformity corrective surgery.
I'm going to take a few minutes just to really thank Dr. Chapman for hosting this type of forum for everybody, and more importantly, for taking Steve Lockey under his wing for a couple of weeks when he did his visiting professorship. What also people don't realize is that while I'm older, Dr. Chapman was a mentor to me for my whole career as well. So he's been vital to, even before he knew he was being a big impact to me when I was reading his work, he's been a big impact directly once I got to know him. So I appreciate that. Steve did a great job picking a series of articles, as Dr. Sharma mentioned. This one is on the predicting the combined occurrence of poor clinical and radiographic outcomes following cervical deformity and corrective surgery. This is from the ISSG group. It was in Journal of Neurosurgical Spine, and it's 2020. So it's really just sort of the onset of us beginning to better understand cervical deformity in a way that's more global. Why is this important? Well, we have a problem in cervical deformity that has pain, disability, and neurologic impairment. So you have a bad clinical problem. And when you have a bad clinical problem, you want to find a solution to it. And so what's the solution is it's their large reconstructive options. And they have variable etiology. They can be from iatrogenic, trauma, degen, tumor infections. And these are often in frail patients. So you have a bad problem that has a high complication rate with a big surgical procedure. So these are really what areas where we need to really study better, and it shouldn't be undertaken by the casual surgeon. So one of the purposes of the study is try to determine the demographics, the clinical and surgical factors that might help us understand what are poor outcomes when you try to address cervical deformity correction. I'm going to kind of talk about limitations of the study as I go so we can have it in our mind and really sort of break it down in that form. But at the end, sort of mention why I actually think this is a pretty good article, but it has a lot of limitations. It's a retrospective review out of 13 institutions. So it's retrospective. It's a short follow-up. It's not here on this slide, but it's only 1 year. And the inclusion criteria included radiographic abnormalities, so Cobb angle for coronal scoliosis, and then C2, C7 SVA, which is a cervical sagittal malalignment greater than 4 centimeters. And then, as we talked about earlier, chin brow vertical angle greater than 25, so loss of horizontal gaze. There was only 89 patients that met this inclusion. So even those 13 institutions, they had 89 patients, and there was only a 1 year postoperative follow-up, both clinical and radiographic. What they defined as a poor outcome is very specific here. You had to have all 3 of the following, so not one of the 3. So you had to have a deterioration of radiographic outcomes at 1 year, poor clinical outcomes, meaning lack of improvement of the NDI, neck disability index, or any change in the objective or worsening of severe myelopathy with the modified JOA, and a major complication, death and reoperation. So it was all 3. I'm going to mention that if you had one of the 3, it wasn't included, or 2 of the 3 as called poor outcome, and that's the final outcome. So there's going to be a higher percentage of maybe minor or less ideal results, but not defined as poor outcome in the study. This table on the right, I'm just going to drill down a little bit. If you look at it, it's always nice when you have a multi-center study or any type of large study to look at what kind of patients that you're looking at and does it match up with yours. This is pretty non-granular. It's kind of bulk data, but the mean age is 61.9, so 62 years old. Slightly predominance of 65% females. I'd have to think back and look at my numbers. I don't know if it's a 2 to 1 in my patient population, females to male. I think that's probably accurate. BMI was only about 30, 29. In Virginia, I don't know, in Seattle, that is that's a nice BMI. It's not too worrisome. Here's the one thing I found interesting. The history of prior cervical spine surgery was 40%, 38.6. So they didn't break it down to primary deformity and iatrogenic or surgical treated in an attempt to treat a previous prior deformity. But I think these are 2 very separate groups. Somebody who comes in de novo with a deformity, and then somebody who had prior surgery either to address a deformity or created a deformity. But again, to get 89 patients, they included everybody out of 13 institutions. But I highlight that a little bit, that 38% had a history of prior cervical surgery. Osteoporosis was only 14.6%, something we're recognizing more in our patient populations for outcomes in spine surgery. Diabetes, 8%. Depression, this is another one they didn't talk much about in the paper. I noted in my patients, but I don't know how to manage it. I don't know if these were true Axis 1, Axis 2, Axis 3 diagnoses by a psychiatrist or a psychologist, but clearly we know that people with depression, they manage pain differently, and pain results in people having depression. So it's very cyclic. Again, not part of this study, but something that I think if we're going to undertake these types of surgeries, we should be thinking about. And then the surgical details real quick. Mean level is about 7. Blood loss was 800 plus or minus 800. So anywhere from 800 cc's up to maybe 2 liters or so. Mean operative time was 6 hours up to 11 hours. And then the approach, very varied. Anterior only in about 17%, posterior only in about 50%, and then circumferential in about a third of the patients. So distributed mostly posterior combined. 3-column osteotomy, surprisingly, or maybe not so surprisingly, 20% of patients. It depends on how you think about it. You might say it's surprising that it's low, and you might say that it's surprising it's that high. Outcomes they did find was higher in patients with osteoporosis compared to those who didn't. And then all the other ones seem to have no real significant difference. Here are some of the factors that had some outcomes when we looked at independent variables, osteoporosis, we talked a lot about. Baseline neurologic status is something intrinsic to the surgeon who's been in practice. We know that neurologic outcome, especially in tumors, the neurologic outcome post-surgery is most correlated with preoperative neurologic outcome. So if somebody has some deficits preoperatively, our ability to regain and restore function in those cases is more limited, especially in the cervical spine because it's cord level dysfunction. So I think understanding what their neurologic surgical deficits is important, and then a series of numbers below that we would look at. I think some of the important ones are C2 to T3 SVA, and then global SVA alignment. They gave 2 cases. This is one that they happened to put up. I think most of us will look at this and say that this is some shape or form of cervical deformity with kyphosis and a prior surgical procedure, and certainly the cervical SVA and all the alignment parameters would be malaligned. We can certainly debate this post-surgical reconstruction, and this is one that fails. Did they achieve the alignment goals, and did we achieve the necessary decompression that was needed? It's hard to know for sure, but this is the one case they outlined as a failure. And they looked at baseline weakness, including gait and hand atrophy. So this is pretty involved once you start getting hand atrophy. They talked about the C2, T3 SVA at 8.5 centimeters, less than 4 is what normal is. And then the pelvic tilt of 18, and then 12 levels of maximal thoracic involvement. So as I said, a lot of limitations that make it hard to understand, but the biggest take home is outlined here, that the full length malalignment, which is pretty underappreciated initially, is starting to come in view, is important for addressing cervical deformity. We touched it on earlier in our conversation, in that when we get cervical x-rays, we are looking at cervical SVA, we're looking at coronal scoliosis, but the T1 slope or the C2 T3 SVA puts your head and neck in space in relationship to your pelvis. So while we understand in thoracolumbar that a PI-LL mismatch is important, if we just focus on the cervical spine and don't realize that there's a global malalignment, you might restore some degree, but still be very much off, and that can still result in problems short and long term. So while everything they talked about was important, there's a lot of limitations. I agree with their key assessment that at the end of the day, getting full length, understanding the full length malalignment and looking at the whole spine can affect how you determine your treatment management, and osteoporosis as a preoperative risk factor. It's maybe not predictive, but it is associated since it's a retrospective study. And the limitations we talked about along the way: small study, short follow-up, heterogeneous populations, previous surgeries. Thank you.
Thank you so much, Dr. Shen. Quick question, Dr. Chapman, and for all the folks out in Seattle. So, here when we assess osteoporosis, we obviously have multiple tools. We're lucky in our Department of Orthopedics here, we have a bone health pathway. So we have somebody here who actually expertise in bone health, direct connection to the Department of Endocrinology. We can send patients there once we've identified they have poor bone health. They're treated with full communication when they're coming back and maybe ready for spine surgery. When it comes to cervical spine, how are you screening patients? How are you assessing their initial screening for maybe osteoporosis, and then making a determination, have they actually achieved any anabolic process after undergoing treatment? Are you using Hounsfield units? Are you relying on repeated DEXA? What's your strategy?
Super relevant questions. And I don't want to besmirch my employer here, which is a corporate entity. I congratulate you on having an integrated bone health program. In the era of corporate medicine, these integrated pathways are more commonly than not amputated due to lack of perceived financial efficacy. A very general statement, if you know what I mean. So in terms of the cervical spine, the DEXA scan is not a very good corollary, although our federal reimbursement agencies rely on the DEXA scan to authorize anabolic medications if clinically indicated. The Hounsfield units have never been completely validated for the cervical spine, but I do recommend getting the Hounsfield units for T2 and T3, which I've seen listed in several articles and which we use. And therein lies my question. Before I come to my question, I want to return the compliment, as nauseating as that might be for people in the audience, to Dr. Shen. Professor Shen, you have been an inspiration for me, and I look at your articles with great interest as a reference. So thank you. Now the question. Cervical scoliosis for me is one of the most difficult things to correct. We all are well aware of sagittal alignment, and we can correct that pretty darn well. My question to Dr. Shen is, how do we measure cervical scoliosis and coronal alignment from the cranium to the thoracic spine best? And any tips and tricks, and that's a big question, to correct coronal malalignment and the subaxial spine?
So I could do the short answer, which is I don't know, and no tricks or tips, but I feel like that is going to be very helpful. So here is the challenge that we all have as we do more and more surgery and look at our patients more and talk to them. There is cervical cranial scoliosis, a cervical scoliosis that could be a radiographic number, but clinically they're balanced. Their shoulder is balanced, their pelvis is balanced. So a curve that's within the cervical spine can leave a balanced shoulder and a head that's centered and the eyes are not tipped. But a cervical thoracic congenital malformation, I'm going to use congenital because they're the most dramatic. A single hemivertebra at T1 or T2 will really accentuate the left shoulder up and the head coronally out to the right or left, typically to the right, left shoulder, head right. That shortened segment coronal scoliosis centered at C7T1 has more clinical deformity in the coronal plane and clinical appearance than a larger curve that's centered lower in the thoracic spine or higher in the cervical because the mobile segments above and below. And that's the challenge I have. A C7T1 deforming the coronal plane from a clinical file or a congenital segment leaves them very unbalanced, even though it's a small curve. And you look at that, Dr. Chapman will look at it, I'll look at it, Dr. Sharma will look at it, and look at that's a problem. And you can see a larger curve in the cervical spine that's more balanced, and if you lock them into place, I think you might be okay versus having to do larger sections of osteotomies in the coronal plane. Your second question about tips, I don't have good tips on how you define it. And I'm hoping that Dr. Lockey and this next generation, with the advent of EOS and all these other parameters and machine learning, will do a better job at drilling down what is important, what isn't. But we just kind of use the gestalt. You've done much better in keeping up to date on it. I still fall back to the gestalt, which is not very good for global understanding.
May I ask another question?
Of course.
Professor Shen, do you mind going back to the case example of that upper thoracic spine fixation failure?
Yeah.
Yep, no problem.
So having a stable foundation for our cervical deformity reduction surgery is critical. share with us, if you can and will, how many thoracic segments should we involve in fixation to try to keep that bowling ball of our head balanced over the cervical thoracic junction?
So, when you get a deformity, you say, where's my proximal fixation point, my distal fixation point, how many osteotomies, and how many segments am I going to grab, and how am I going to grab them? So proximally, I think it was okay with C2 here. If you look at the pre-op, I am like you, not sure without a full length how distal. If they had a T2 or T4 to T12 was very kyphotic, I might go a little bit more distal. Obviously, osteoporosis. I do think multiple anchor points is becoming a bigger understanding. Grabbing the spine as many places as you can, maybe using alternating screws and dual rods. Not so much just as operators, but grabbing the spine as many places as you can, and multiple segments, and even within the same segment. So I think in this particular case, what I can see here, they have compression factor too. So I think the failure at that lower instrument vertebrae from osteoporosis as well as pull-out, because there's a compression factor. I would agree. I might have gone a little bit more distal, but as you go more distal, then you're in the apex of the thoracic kyphosis. So either you're going to choose to go 2-3, or you're going to go down past T7, T8. That becomes a large surgery. So proximal T2, distal C3. Maybe if you got better cervical sagittal alignment, you could stop. This would have been maybe okay stopping in the upper thoracic if you got a better cervical SVA. I think to your question earlier, this malalignment puts much more stress than if you had a T1 tilt and a better cervical SVA that was more shorter lever arm. So maybe that could be something, maybe a few more osteotomies and or more anterior column, refilling up the anterior column to get a better and a shorter cervical SVA. What are your thoughts? Where would you go this through?
I struggle with that. We've actually had a distal failure interesting case conference with our UCSF colleagues, and it escalated into going more and more caudal. None of us have a good answer. And in fact, I have a bounce back now of mine of an upper thoracic osteotomy with a beautiful realignment. And now, despite distal junction cementing, the patient is breaking at the distal junction area. It's extremely frustrating. And Dr. Lockey's point of however much we can try to optimize bone mineral health with pharmaceutical aid helps, and re-education of patients' muscle activation. It's a very frustrating subject. Go ahead.
Do you think we're stuck a little bit though? In thoracic lumbar deformity, they're often not neurologically as involved as a cervical thoracic. So thoracic lumbar, we might put them on a year and a half or a year or 6 months of Porteo or something. But in the cervical spine, the thought of going a year and a half, 2 years, if they're myelopathic, becomes less eager. It's a little less. We're a little less encouraged by, excited about that prospect out there. We're stuck.
In your paper, you said that dual core rods, so the kind of a dual diameter rods, had a higher failure rate. Is this a reflection of having used them in more thankless cases, or is an inherent biomechanical problem with those devices?
Yeah, I don't know. This one they talk about transition rods, and they didn't drill down too much. So that's the 3.5 to 4.5 or 4.3.5 to 5.5, whichever system you want. And I don't know. I've gone away from that. I've gone away from transition rods for various reasons. It's hard to contour as stress riser, I think, at that level. And maybe I was younger, not understanding the challenges. But I don't know in this paper what they're specifically talking about, why transition rods work. But I think it is to some degree stress on the rod, or maybe not fully understanding how to transition from the cervical to the thoracic spine, which are different anatomies, smaller pedicles, lateral masses. things like that. So I don't know the answer to you for this paper, how they found it, why.
Okay, our last paper is the morphology of the cervical deformities, a two-step cluster analysis to identify cervical deformity patterns, presented by my senior partner, Professor of Orthopedic Surgery here at UVA, Dr. Scheimer. Dr. Scheimer is a major thought leader also in the Cervical Spine Research Society. I'm lucky to have him as a senior partner, as he and Dr. Scheimer have taught me a lot about the cervical spine. Dr. Scheimer.
Too kind. We pay them good money to say that about us. Well, again, like everyone else said, I want to thank Dr. Chapman and Seattle Science Foundation for having us. It's a real joy to sit and talk about spine surgery. It's probably one of the most enjoyable aspects of this job, particularly around cases. And not to go back to that previous X-ray, but I think it dovetails nicely into this paper. It was curious that they showed that, because I don't know if you would have seen the immediate post-op film whether they ever met their alignment goals, right? So I would go back to what distal fixation points are important, but let's remember that the primary goal of deformity correction is to define where the deformity is, define correction goals, and meet those goals. And when you don't meet them, we know in thoracolumbar construction, the rates of PJK go up remarkably whenever you don't hit those goals. And I think that last case kind of speaks to it, because if you look at their T1 slope, it was a pretty flat T1 slope. So I don't think it was a thoracically driven cervical deformity. I think that was like focal cervical deformity that probably wasn't addressed correctly. Sorry, we should be talking about papers. So I'm going to speak on the morphology of cervical deformities, a two-step cluster analysis to identify cervical deformity patterns. This again was done by our illustrious colleagues in the ISSG, published in 2020. I think it was actually the same cohort of patients as Dr. Shen's. I think they looked at this data in a couple different ways. So not to go through all this, but we want good cervical alignment. We don't want cervical deformity, particularly in the sagittal plane. Go back to one other question I didn't mention. Is sagittal deformity, I think often, or coronal deformity, I think you can actually get in trouble with trying to overcorrect them and throw them off. A balanced cervical coronal deformity has to be respected, and the standpoint is if you level out all those discs, you can actually push them into deformity. Anyways, I'm going back and forth. So energy expenditure increases, much like it does in global spinal alignment. If you can't look forward, you have a low quality of life. Treatment of cervical deformity is complex. I would argue the understanding, diagnosis, and quantification and qualification of cervical deformity is complex. Previous studies have attempted to kind of classify these into groups so we can have a shared language amongst us spine surgeons about what we're actually dealing with. So it's one thing to say, oh, that patient has a cervical sagittal deformity, they can't look forward. But if you don't kind of know how that curve looks or behaves, it could drive the way you take care of that deformity, and maybe take care of that deformity in a way that's not optimal. So this is just kind of a pictogram of some of the alignments or some of the alignment parameters we look at. I want to speak specifically about T1 slope. And I think it's really important to think of T1 slope much as we do pelvic incidence. And much like lumbar lordosis should match pelvic incidence within 9 degrees, the cervical lordosis should match the T1 slope within 17 degrees. So I want everyone to keep that measurement in line, because when you hit that parameter of 17 degrees, it puts you right in the window of cervical SVA of 4 centimeters. And we know that cervical SVA over 4 centimeters, much like C7 sagittal vertebral axis, over 7 or 8 centimeters, puts your quality of life and energy expenditure much up. So this is a retrospective review of a bunch of patients, all collected through the ISSG. Inclusion criteria is the same as Professor Shen's inclusion criteria. They looked at radiographs, demographics, clinical parameters, including patient-reported outcome measures. And then a group of 12 spine surgeons sat and looked at these radiographs and tried to cluster them into 3 main groups. And we're going to kind of speak about them. And what I'm going to try to do is speak more generally for the audience, because I think it's important to kind of get a concept of how these all fit in. So the radiographic parameters that were significantly correlated with patient-reported outcome measures were max focal kyphosis, C2, C7 flexibility. We talked about the thoracic or T1 slope and cervical lordosis mismatch, max kyphotic flexibility, and these parameters were put into three distinct groups: flat neck, focal cervical deformity, or cervical thoracic deformity. And I actually want to talk about the first and the third group as one, and then the second group, because I think they're very different. I think those two kind of subcategories are similar. So focal cervical deformity can correct their T1 slope. They can retrovert their T1 to kind of put their skull over their pelvis and their spine, much like someone with flexible hips can retrovert their pelvis to stand their spine on top. Whereas both a flat neck deformity, or what I would call drop neck deformity, and a cervicothoracic deformity has a high T1 slope. And I would kind of make the difference between those two groups as a flat neck deformity or a drop neck can't correct for the T1 slope, and the cervicothoracic deformity can partially correct. So they have a high cervical lordosis. And that's what all these numbers here, not to torture everyone with the numbers, but essentially that's what you can see. This first group, or the flat neck, has the drop neck. So they both have a high T1 slope and a high C2 slope, resulting in a very profound deformity, inability to maintain horizontal gaze. The group two, they retrovert, or they can stand their T1 up, probably through a flexible or well-aligned thoracolumbar or global spine alignment. And they just have one focal deformity. I would actually argue that radiograph from before fits more into group two than it does into group one or group three. And group three are these ones that we see that have this big dramatic thoracic kyphosis, yet compensate pretty well with the cervical lordosis. And what you don't want to do with those patients is fuse them flat, because then you turn them into a group one. So again, all of these granular, nuanced alignment parameters are important, but I think the overall concept of how these three groups are is actually very important, because it drives how you treat these deformities. So if you have cervical malalignment, they all do not well in terms of patient-reported outcome measures, and this is important. So you can't say, well, group one does worse than group three, or a flat neck does worse than a focal cervical deformity. They all do equally bad. So once you define a cervical deformity with a cervical SVA greater than 4 centimeters, a C2 slope greater than 20 degrees, they do poorly. And the drivers of these deformities are different. So 80% of patients with a flat neck had a cervicothoracic driver. This is what we talked about. So flat neck, drop neck, they have a high T1 slope, yet they don't have the muscular tone or ability to bring their head up. Very challenging deformity. They are usually flexible, though. And nearly all of the focal deformity had a cervical driver. That makes sense. So they're able to bring their T1 back. They're able to flatten their T1 to stand their neck up. So all of those, nearly all of those had a cervical driver. They did not have a thoracolumbar deformity. And in cervicothoracic deformity, 55% had a cervical, or 45% had a cervicothoracic. And you can see all the numbers down here. I want to speak specifically about this T1 slope. You can see group two has a much more normal T1 slope than does group one and group three. And the flexibility of these deformities are much different as well. You can see there's very low flexibility in the drop neck and of the focal cervical deformity compared to the very flexible cervicothoracic deformity. So the type of severe cervical deformity affects global alignment and reconstruction options. Patients with a flat neck deformity is most likely to be passively correctable. Consider preoperative traction. I think that's often debated here, and that'll be a good first question for Dr. Chapman with these kind of big sweeping drop neck deformities that also perhaps have a component of thoracolumbar malalignment. Do you place them in preoperative traction and kind of see what you get? Long length constructs should be considered. These are the ones you need to get a big bite into the thoracic spine because of the high risk of distal junctional failure. Focal deformity. So you have compensatory C1 slope. You can bring your T1 back. So usually if you do a really nice focal deformity correction. Like that x-ray that was shown, I probably would have done a couple level anterior, and then in the back, you probably could have stopped at T2 or T3, because I think you would have put their C2 slope flatter. You would have made their cervical sagittal vertebral axis within 4 centimeters. And you can keep your constructs contained within the cervical spine. I put an asterisk on here and said maybe you don't need to go as distal, because fixation within the cervical spine, maybe if you have a posterior component going down to T1 or T2. And patients with cervical thoracic deformity have this hyperlordosis cervical spine and a big T1 slope. If they're primarily complaining of cervical deformity, these patients often don't, because they have such a big degree of cervical lordosis that they can kind of get by. If they're complaining of horizontal gaze, you want to look to the thoracolumbar spine first. You need to get long-standing radiographs because you need to flatten their T1 slope. And what's interesting is these patients often commonly get occipital neuralgia. This is kind of a little bonus for Zishan there, who looks like he's in a bunker. It is that because you hyperextend through your OC junction too. So these people with a big thoracic kyphosis, when you hyperextend and you have remodeling at the bottom of the C1 ring, you pinch your greater occipital nerve. So patients in these type 3 can often have occipital neuralgia. So find the thoracolumbar driver, fix it, or at least consider it. And again, the precise measurements are important in these 2 groups, but just to understand them as a concept is actually really important because it drives your correction. Thank you.
One slide.
I would applaud, but I'm holding my own camera phone. The room is applauding. So that was awesome. 3 take-home points for me, and that's all in the setting of who is the patient, how well are they, or frail, and what's their neurologic status. The 3 points are that I learned from this: rigid or flexible curve. What is the driver of the deformity? I'm assuming Dr. Shermer's excellent term here. And the third thing is capability of the patients to activate their extensor muscles. So in these 3 things, are we at a point of having a checklist, Dr. Shermer, with your political and academic influence, where we can kind of offer our next generations a algorithmic checklist?
You're too kind. I would not consider myself a thought leader, but my answer is yes. And I think that we've actually become pretty good at understanding thoracolumbar deformity. And the corollary between cervical deformity and thoracolumbar is remarkable, actually. And in fact, you have a lot more power in the cervical spine because you have the ability to correct the thoracolumbar spine. You can correct the pelvis. You can do pelvic osteotomies, but those are very challenging to do an S1 subtraction osteotomies. Those are challenging. So I would argue that the first thing you need to do to the junior listeners and learners in the room is to meet your patient and to understand what their chief complaint was, right? So not all cervical deformities are cervical deformities. They might care not one bit about their cervical deformity, but they have myelopathy or they have cervical radiculopathy. And perhaps if you treat that without accentuating or worsening their alignment, they're happy patients. If their primary complaint, and as you see them, is inability to maintain horizontal gaze, and I keep coming back to that because I really do think that matters, then I would look to the C2 slope, the T1 slope, and the cervical lordosis. You can derive nearly all of your treatment algorithms from those 3 parameters. And T1 slope is key. It's like looking at the lumbar spine and not looking at the pelvic morphology. Like it's just, I'm hoping that as we move on, when people look at lateral cervical spine x-rays, they will look at the T1 slope and get a sense of what even if they don't have long-standing films, because you can kind of learn infer, I should say, what their thoracolumbar alignment looks like by the T1 slope.
And I want to credit Dr. Chris Ames from the ISSG for having introduced us to this T1 slope. I could not agree more.
Yeah, I want to recognize specifically Dr. Ames. I think he's one of you want to talk about thought leaders. I think a lot of his ideas around cervical deformity have really moved us forward. There's perhaps some things in spine surgery that doesn't always move us forward, but really thinking about it, talking about it, what's important, what's not important. I thank him and congratulate him as well.
So we're past the 7 o'clock hour here in the West Coast. I'm gonna get kicked out here violently because there's an ENT conference starting. Dr. Lockey, do you want to close out our session this morning?
Sure, Dr. Chapman. I thought that these articles were nice because they led into some of the foundational understanding that we've developed since 2020. So hopefully helpful for the fellows and resident learners out there. And thank you to you and to all your colleagues out there for inviting us. We really enjoyed it. We hope to come back sometime soon and hope to catch up with you at a conference in the near future. But thank you for having us.
Thank you, UVA.